Welcome to Symposium 17. I'm Dr. Mike Powers from Dornbecker Children's Hospital in Portland, Oregon. We're kicking off lessons learned from COVID-19 pandemic, and I have the pleasure of presenting the work from the CF Learning Network Telehealth Innovation Lab. I have no disclosures. The Cystic Fibrosis Learning Network was established approximately 5 years ago to advance our care beyond the traditional chronic care model into one in which we envision learning from every interaction between clinicians and patients. We had a design phase and then a pilot phase with 2 waves of team. And then over this last year, we've onboarded 16 additional programs. We have a network leadership team that's made up of parents and adults with CF, as well as clinicians, and a true co-production approach to quality improvement leadership, where we all have a voice and we all share in shared decision-making. The CF Learning Network currently has 39 programs, and in fact, we onboarded 16 new programs during COVID-19, and it did impact our ability to fully integrate them into our program without face-to-face meetings, but we've adapted through virtual meetings. Our focus areas prior to COVID included clinical information systems, which means data entry. We need to learn from our data in QI, and so we have a goal of entering our data at least every 30 days into the registry, as well as other data that we use locally in our learning network. The other big emphasis in the CF Learning Network, and the game changer for me personally, was co-production of quality improvement efforts, as well as the care that we provide. Another big emphasis is on collaborative and clinical pre-visit planning, and that's part of an informed patient and family, provides a better clinical experience for them and better outcomes for them as well. And the team is better prepared too for the visit. And over the last year, we focused on FEV1, identified exacerbation signals, which is FIES, and then health-related quality improvement in quality of life will be points of emphasis this fall that we're trying to kick off. And you can see all the teams that have joined there on the right side, just a good wealth of balance of adult programs and pediatric programs. However, COVID-19 happened this March, and we had to take advantage, unfortunately, of the crisis, and because our current QI processes were disrupted. We were looking at FEV1, and all of a sudden clinic visits stopped, lung function testing stopped. So how would we continue as a network? What would serve our patients the best during the pandemic? And what would help our teams reprioritize their improvement work? And telehealth seemed like a natural fit. So our leadership team actually activated themselves to be the designers of this new telehealth, what we call Innovation Lab, an opportunity for teams to learn from each other and test rapidly. So this is just an outline of this Innovation Lab process, where you have a pre-designed process where you look at the scope of the project, what's your improvement design, what sort of pre-work do we need to do. We had a design meeting with team members of the leadership team, as well as operations teams, quality improvement consultants, and telehealth experts. And we developed the key driver diagrams, aims, interventions. Then we launched this project to our entire network and invited all 39 teams to join. And we oriented them, and they committed to this process. And then the key to this is rapid testing, where we had weekly huddles initially, and now they're twice a month. And we have weekly measurement. We turn in data weekly, and we can learn from each other. And we have what's called orchestrated testing, in that we look at it as leaders of the iLab, see what PDSAs we want to suggest our network teams do. As you can see, this timeline was dramatically compressed into 3 weeks instead of the usual 6 months to kick off a new innovation lab. So we use the COVID-19 crisis as a rapid pivot to this new project. And here's just showing that design phase, and I wanted to share a few quality improvement tools that we used, and I'll review those at this time. So the first tool we used was called FMEA, which is a failed mode's effective attributes. And so we looked at these interventions here, as well as the barriers here in the red, and at various processes of the telehealth encounter, pre-visit, scheduling, the actual encounter, post-visit, all those steps. We looked at what the barriers were and what the potential interventions could be. And then we looked at that in our design meeting and came up with helping us think about potential interventions and measurements. Here's a key driver diagram, and this is a good thing to use to help organize your thinking around your improvement project. And again, our global aim was to deliver interdisciplinary, co-produce CF care via telehealth in the midst of the pandemic. And our smart aim actually was to increase our telehealth visits up to 95% as effective visits with multiple team members and co-produced. And I smirk a little bit because that's a very high bar to hit. And then the population obviously was our CF patients and families. Our key drivers, as I mentioned, were interdisciplinary care coordination and delivery and co-production care in families. And you see all those other items in the white boxes. Those are things that we felt were important, but in our thinking, we didn't have the capacity to attack all those things at the initiation of the lab. So we focused on the two top key drivers. And again, this information and this data was thought about from a design team, quality improvement consultants, and other faculty from the Learning Network that we came up with these approaches. And here we had our launch meeting, and then we asked our teams to commit to this process, and we gave them about a week to make a decision, and we had our first huddle, and we recommended their first step was to develop a process map. And again, some of the examples of co-production and telehealth design included virtual testing of these platforms before we rolled it out to all of our patients. Some of the family members and patients and partners created handouts and co-created newsletters about telehealth visits to share with our entire center population. And then we also co-hosted some town halls around telehealth. On the right is a handout that our families designed and developed around educating people around telehealth. And again, here's a process map that the UVA adult team developed. And again, a process map is something you can use to help organize your thoughts, look at challenges to the flow of your telehealth visit. So I highly recommend that you develop a process map for your center. Here are some tests to change. And again, we orchestrated different PDSAs over the last 6 months, focused on interdisciplinary care, agenda settings, starting small, starting one provider, starting with a couple patients, and you start small and you ramp up as things become more reliable. Our team is now on our 23rd ramp over the last 6 months on the telehealth PDSAs. So this is testing. It's really critical. You learn from data and you modify your approach to care. Here is just the number of PDSAs that teams have submitted, and we started out with about 1.5 per week. We're down to about a little under 1 per week because we've gotten to more of a flow. Obviously, we had a ton of learning to do in the first couple months of the pandemic. Here is some telehealth pre-visit planning approaches from our networks that you could learn and share. The initial step is to learn about what's the preferred method of communication from your family. And you need to provide education around the technology of the telemedicine platform. Then you have to learn how to, what that communication in terms of that pre-visit planning is key. We've had challenges with people answering the telephone, and what we've learned from other teams is text messaging is the way to go. So we entirely encourage you to develop a text messaging process that's HIPAA compliant at your institution. Teens will engage and young adults will engage in that process. We also recommend electronic huddles. We've learned from how to do that with Zoom, WebEx, and MS Teams. And again, the final way you can pre-visit plan or agenda set is the day of visit. You can ask about that at the beginning of the visit with the patient. On the right is a pre-visit planning form that Children's at Salt Lake uses and as an example, and part of it is around pre-visit planning, and part of it is our tips for a successful telehome appointment. Here's another tool that you can use and learn and adapt. It's an electronic whiteboard, which is used for communication during the clinic visit. As you can see, Google Docs is one option. This is a team for Virginia that used that to kind of see where people are in the visit, who the patient wants to see. MS Teams is something we're going to try and learn and adapt as a team, as a local team. Currently, we're using a Skype chat room to communicate about when to come in and out of the virtual room with the patient, when to invite other providers into the room. So we're going to transition to thinking about not PVP, but the agenda setting at the time of the clinic visit. So here is the concept of what matters to you versus what's the matter with you. And this has been in the literature for about the last 10 years. And again, person before patient, developing rapport with people. And then I always emphasize person before provider. So I want to share things about me so we can have some shared humanity during this clinic visit. And I've mentioned, I've shared my son growing up with, and daughters growing up with patients and families as their children have grown up as well. And we kind of compare notes. So that's shared humanity. And again, the other aspect is to be empathetic during that clinic visit while you're after you set the agenda. And this is a great resource that the CF Foundation's PEP program developed in collaboration with the Academy of Communications in Healthcare. And there's a link at the bottom that you could look up. A wealth of information actually at the ACH's website as well around COVID-19. Here is some data now. Here's where the rubber meets the road. Interdisciplinary care, and this is where we initially around 60% of clinic encounters had interdisciplinary care approaches, and now we're around 85%. And this is from weekly data entry. You look at all the clinic visits at the bottom, 200 to 300 visits are being entered weekly by our learning network. And we love that we have a shift now and are close to our new goal, which is at 85%. Here is more data as well around agenda setting. And again, we had a shift recently as well in July, where we were initially about 70%. Now we're up over 90% of our clinic visits have agenda setting, either through a pre-visit planning process or via a face-to-face agenda setting during the clinic visit. The key to this, the key to understanding that you're implementing successfully is to measure it. Measure what you're doing. Are you doing this pre-visit planning? Are patients and families responding to your questions? And are people responding during that clinic visit itself? You have to engage them. So with some data from some of our families, we had the opportunity to participate in some surveys around telehealth. UAB, in conjunction with Boston Children's, developed a survey for adults as well as children, and we participated in that. And about 8 teams from our learning network participated in getting feedback. And I just are sharing this one bit of data just to give us some insight to the future. If telehealth visits were offered in the future, how many visits would you prefer be completed by telemedicine? And it's pretty shocking. 50% of the adults want some of their visits, and 34% want most of their visits done by telemedicine. And again, on the pediatric side, 70% wanted some visits, and 22% want most of the visits. It's interesting, the concept difference was the pediatric families understand they still need to get those cultures quarterly, and so that's kind of one of the barriers to telemedicine at the current moment in the pediatric patient population. So what are some other access challenges and innovations that I want to just to briefly touch on? One is we got to think about equity in telemedicine, and we must ensure that care is equitable. I participated in an Institute of Healthcare Improvement discussion panel, and that was one of the major emphasis. We have to make sure telemedicine is safe and equitable and is co-produced, which has been the emphasis of the learning network. But so what are some of those key actions that clinicians and healthcare systems can do to try and ensure it's equitable? One is to measure and identify potential disparities. Measure it. So we measured who was non-English speaking, and we also measured who did only phone visits. versus video visits. So we dug into those two populations to see if we can remove barriers and enhance care to that patient population. The other key item is to develop education and training to mitigate digital literacy issues. Also, a key thing is to inform people about the reduced or free broadband internet that's been sponsored by the government during COVID-19. And again, another key is to ensure adequate language interpreter access. Our platform locally is using Zoom through Epic, and it has incredible methodology to integrate an interpreter, either on the video or just with audio. So it's worked quite well, actually. And again, we need to increase awareness of some of these barriers to our institutional leaders if we need some additional help breaking down these barriers. And again, long term, we need to advocate for permanent and equitable access to broadband internet to all of our patients throughout all the country. And we need to advocate for parity for video visits by all payers and make sure that continues beyond COVID-19. Access and billing challenges and innovations. I just wanted to touch base on the licensure. So we got special permission here from Portland to see patients from Southwest Washington. It was sort of a blanket agreement between the two states. And so we need to ensure that continues once COVID-19 is over, hopefully in the next 2021, hopefully. The other challenges, though, have been multidisciplinary team members. Sometimes they weren't allowed to do video for a while. It took a while to onboard them. And our RDs have to use video, actually, to bill for their services during the clinic visits. One pearl I wanted to share is, our hospitals have limited visitors, and usually a parent can come with a child. Rarely two parents can come, but other children are not allowed to come. So a local foundation is supporting single parents here in Portland by providing free childcare to the family so they can attend their clinic visit and make sure other kids are safe. And then I wanted to mention, over time, as in-person visits ramp back up and we start to recover that facility fee, that billing issue that the hospitals are worried about, we're going to need to maintain the telehealth programs because our parents and patients want that. And also, it will improve access to care over time, and it can grow your clinical program. So we've got to think about the future. So other clinical delivery innovations include social workers using electronic platforms. We've got to figure out how using drive-by sputums in external labs. And I think the big breakthrough is hybrid visits. That's a big innovation. We're part in-person, part virtual. And a lot of our teams in our network have adapted and developed really robust processes because our social workers and dietitians are still restricted from coming to the hospital. So in summary, telemedicine implementation at the Learning Network, we've been successful in meeting our goal of 85% of visits with interdisciplinary care and shared agenda setting. We've co-produced these QI processes at all levels, and it's really helped clinician and patient and family member engagement. And also the other key is that weekly data collection and twice monthly huddles has facilitated rapid learning and improvement. In improving these process and outcomes, okay? So again, telehealth will continue to be a tool in the toolbox for CF clinical care. Patients and families want this, and so we need to approach it, and it may enhance access to care, as I've already mentioned. But we do need to further refine triage processes. Should this visit be in person? It should be virtual, sputum collection, home spiro, external labs, health screening. We've got to enhance this to enhance telehealth in the future. And as I mentioned, we need to ensure safety and equity in telehealth care. Finally, I'd love to thank all the teams and team members that have participated, our CF Learning Network leadership team, our telehealth iLab leaders and quality improvement consultants, operations team, faculty, CFF leaders, as well as, Lucretia K. Thomas. She's been the workhorse of this process, and she is the first author on a poster that our network is sharing with the rest of you. I just wanted to briefly mention that we have some telehealth resources on a slide here with some live links, and I've listed some references that you can look up. So please ask questions in the chat, and I'll monitor that. And also, send in questions in the Q&A for discussion through the live discussion on the third day of NACFC. Take care.
Welcome. I am Beth Smith, Professor of Psychiatry and Pediatrics from the University of Buffalo School of Medicine and Chair of the Cystic Fibrosis Foundation's Mental Health Advisory Committee. Today, I'm presenting on behalf of this committee on the mental health impacts of the COVID-19 pandemic on the CF community. These are my disclosures. I receive grant support from both the Cystic Fibrosis Foundation and the New York State Office of Mental Health. Starting with some background, the COVID-19 pandemic has been very stressful. There was fear and anxiety about a new rapidly transmitted disease. There's fears about being contaminated or contaminating others, fears about the risk of mortality associated with COVID. That together with our loss of routines and loss of our self-care activities like going to the gym or going out to eat has made this a particularly stressful time in many of our lives. Special events have been canceled. People are feeling very isolated, and some are feeling the economic impact, which all can lead to increased stress and anxiety, and ultimately increased rates of depression and substance misuse in our populations. Today, I'm going to draw on 2 surveys from the CF community and compare those results to studies on the effects of the pandemic on mental health. To start, what do we know about the impacts of pandemics? Well, most of the literature comes from SARS, which was more limited in nature, and the outbreak was contained within a few months. But studies on large-scale disasters have found increased rates of anxiety and depression, trauma symptoms, substance misuse, and even domestic violence and child abuse. There have been a number of recent studies on the mental health impact of the pandemic. I'm not going to go through all the studies and do have some additional references, but would like to highlight a few, especially the first study that came out of China and the next that came out of Hong Kong. These 2 studies both show the rates of depression in their adult populations to be between 17 and 19%, using cutoffs of moderate to severe depression. The rates of anxiety fluctuated between 14 to 29%. And in the last study, 25% of individuals reported that their mental health worsened as a result of this pandemic. What about the effects in adolescents? Well, a large study came out of China with over 8,000 adolescents using the same screening tools that we're using in our CF clinics, the PHQ-9 for depression and the GAD-7 for anxiety. And they used a different cutoff. They used mild to severe and found 44% of the adolescents were depressed and about 1/3 were anxious or had comorbid anxiety and depression. When you look at these graphs, this was the breakdown by severity. And what you'll see for depression is that about 18% of adolescents had moderate to severe depression and 10% had moderate to severe anxiety. And again, remember those numbers because we're going to compare them to what we have found in our CF communities. Risk factors included being female, living in a rural community, which may have been a proxy for economic status, and higher grade level. And the higher grade level may have been more of a loss of special events experienced in these adolescents. Because the literature from other countries may not reflect the experiences of persons in all parts of the world, I'm also going to review some US data. This is a study that sampled over 2,000 adults in the US in late April and compared the data to nearly 20,000 adults from a National Health Interviews survey in 2018. And what they found was that currently there's an 8-fold increase in serious mental distress. And if you include moderate to severe distress, almost 70% of individuals screened were endorsing moderate to severe distress as a result of the pandemic. And this was highest in younger individuals, married individuals, those with children at home, and Asians. And for any of you who have children at home and have been trying to balance that work-life phenomenon and becoming, at-home educators, you could see why this might be a particularly at-risk group. Next, there was a study from the Pew Research Center that recruited adults through national random sampling of residential addresses. They surveyed over 10,000 adults in April of 2020 and asked if over the last 7 days they felt nervous or anxious, depressed, lonely, how hopeful they felt about the future, or had trouble sleeping. And what they found was that about a third of the individuals were categorized as highly distressed. And those that were most distressed were those concerned about the health and economic impact of COVID and those with an underlying disability. There was another study that received a lot of national attention and made multiple news media sources. And this was a study from a self-screening website. So this meant that individuals had to go to that website and look for mental health screens. They specifically looked at the PHQ-9 and the Prime MD PHQ for anxiety. And what they found was that a lot more individuals were going to their site to self-screen. And 88,000 plus individuals screened positive between February to May than in the preceding 3 months. And what they found was that the scores were also increased. And again, it's hard to look at the exact numbers of percent positive because those were people that were self-referred looking for screening tools. The main contributing factors in May and April and May were loneliness and isolation. And another notable finding was that 10% of individuals were screened for depression reported feeling or thinking about suicide. Another study of over 5,000 adults used some tools that are similar to the ones we used. They used the PHQ-2, which is the first 2 questions on our PHQ-9 asking about depressed mood and anhedonia or limited pleasure in things, and the GAD-2, the first 2 questions on the GAD-7, asking about things like worry, restlessness, and an inability to control that. And what they found was nearly 1 in 4 individuals had depressive and anxious symptoms. They also used a stress-related disorders screen and found that 26% of individuals endorsed trauma and stress-related disorders that were specifically related to COVID. 13% increased their substance use in order to help cope with stress related to COVID, and 11% reported seriously considering suicide in the last 30 days. This is a recent study of suicide in the context of COVID and just shows who some of those vulnerable individuals are. So if your center is not screening right now for depression, it might be something to consider, especially in these vulnerable populations. And those include individuals with pre-existing psychiatric disorders, those in your high prevalence COVID areas, and anybody who lost a family member or friend to COVID. So in response to what we were learning in the general population, we created 2 surveys. This survey that I'm describing now is from a mental health prioritization survey. So it was a survey being sent out to help us prioritize research topics on mental health and CF. However, because it was coming out in late July, early August, we also added a question about the impact of COVID on mental health. And we want to thank individuals from our community as we had nearly 700 responses. And what we found when we asked how individuals with CF and their caregivers feel the coronavirus pandemic has impacted their health, that 29% of persons with CF and 29% of parents felt there was a major impact. If you add up the categories of moderate and major, 70% of our parents and individuals with CF felt there was a moderate to severe impact, which is very similar to some of the other research we just saw. And there was a study that came out by Kaiser at the exact same time looking at the impact of COVID on mental health. And over 50% of adults surveyed felt that COVID had impacted their mental health. So again, we're seeing a little bit higher numbers than that survey, but very consistent with some of the others on distress. We then looked at specifically the effects of modulator and transplant status. So this graph shows that for major impact on mental health, if you are eligible and taking a modulator versus eligible but not taking a modulator versus not eligible at all. And what you'll see is those that are not eligible have the most severe impact on their mental health, with 37% of individuals endorsing a major impact. We were also concerned about transplant status because those individuals may be at the highest risk for morbidity and mortality from this virus. And so for those that already had a transplant, 32% endorsed having a major impact on their mental health. Our next survey was part of a series of surveys that were constructed by the Mental Health Advisory Committee. We had been surveying all programs that received mental health coordinator grants over the last few years. This year, we modified the survey and sent it out to all programs to include the impact of COVID-19 on their mental health programming. This was a 38-item survey that was sent to all CF program centers and affiliates, and I am so pleased to say that 139 programs were represented in this study and completed the survey, even though we were only had the survey open for less than a month. In this sample, 65% of centers represented those who at one time had a mental health coordinator grant versus 35% that did not. However, when we split the data, there was no difference between these groups. 40% of programs were combined. The rest were from pediatrics and 24% from the adult programs. So what we looked at was how is care being provided by the team versus the mental health coordinator or mental health professional on the team. 57% of the mental health folks were seeing individuals with CF and caregivers on the same schedule as the rest of the clinic. However, when we looked at the mode of interacting, most teams were interacting via telehealth with audio and video. However, most of the mental health professionals were interacting with video and also with the telephone. What we found when we looked at the programming was that 63% of programs, or nearly 80 programs, continue to screen for depression and anxiety in persons with CF. 60%, however, were screening less frequently, and only 15% of the mental health professionals were actually getting reimbursed for the services they were providing during this time. When we looked at the numbers for depression in this study, we actually put a cutoff at moderate to severe. And we did this because there was a lot of controversy over whether mild symptoms were part of some normative responses to the pandemic versus a mental health problem or disorder. So we decided to cut off the survey at moderate to severe symptoms. And 12% of our CF population is experiencing moderate to severe symptoms of depression. When we looked at anxiety, 13% were experiencing moderate to severe symptoms. When we looked at what kind of interventions were being provided and the percentage of folks that were being provided interventions by team members, we were really surprised to find the large number of folks that are receiving mental health services during this pandemic from their mental health providers on the team. So having those folks embedded, before the pandemic really helped them to be able to turn their focus to provide comprehensive resources and also in the moment therapies for individuals. When we look specifically at suicidal ideation, we were worried about the impact of COVID-19 and if it could lead to thoughts about suicide. And 3% of persons with CF that were screened for depression endorsed suicidality. And I just included some national resources for this. And all of those national resource centers have reported the numbers of folks calling these hotlines has grown exponentially during this pandemic. I mentioned that the Mental Health Advisory Committee has had multiple years of this survey. And so this is a comparison of year 1, 2, and year 3. And again, there's a lot fewer individuals screened, but this was only for a small portion of the year, specifically during the pandemic. What we found in years 1 and 2 was a little different from what we saw in the original TIDES data, and that nearly 50% of persons with CF had at least mild symptoms of depression and or anxiety. Again, we cut this sample at moderate to severe and found 12% during COVID are experiencing moderate to severe symptoms. The rates of suicidal ideation have really held steady. What about results for caregivers? So of the programs that were screening before COVID, 60% continued to screen caregivers during the pandemic. We have results from 173 caregivers that were screened during COVID using the PHQ-9 and GAD-7. And what we found was only 6% had moderate to severe symptoms. And so this is less than what we saw in persons with CF and clearly less than what we see in the general population. And so again, this is a very resilient group of individuals, but there's still a need to screen and intervene in this group. This is a chart of depression in caregivers across those 3 years. And what we saw is about 1/3 of caregivers had depression in years 1 and 2, and again, much lower rates in that moderate to severe range during COVID. We also then looked at barriers to screening during COVID. And we, as the Mental Health Advisory Committee, put out many posts on our listserv about tips and tricks for how to screen during this time. But there were a lot of difficult logistics. How do you contact patients? How do you collect the data when we're used to screening on paper? Where do you store the data? And again, with caregivers, we also saw that difficult logistics was the most cumbersome. And this was something that we saw in years 1 of our Mental Health Advisory Committee survey, but had really worked itself out over the years. But now with the new telehealth platforms, this again rose to the top of our barrier list. What about positive outcomes of screening? Well, you know, we heard a lot about the increased focus and attention on mental health. And this was something that is going to, again, help move the needle and reduce stigma. We heard about early identification of mental health concerns so people can take more of a preventative approach, and that there were actually more access or increased access to services via telehealth platforms. There was also a lot of praise from both within the institutions and individuals and caregivers who are very thankful for being screened. What about changes in the role of the mental health clinician? We were really worried about things like being furloughed or individuals being pulled to other teams. 27% of respondents had no change in their role. However, 15% were being pulled out of their CF clinic to help in their larger institution. Some of the new roles people had within their team was helping to facilitate discussions on the mental health impact of COVID on their CF team, developing and collating supportive resources for their patients and families. For example, things like, you know, online grocery shopping, where to get food, you know, from food banks, and et cetera, and providing support to teams and their larger institutions. Most common responsibility was actually trying to link folks with practical resources within their community, but also providing actual interventions. 40% of respondents were providing individual telebehavioral health therapy sessions, and 6% were providing group therapy. The perceived barriers to continuing our services in a telehealth manner after COVID include the ability to bill, and again, we saw only 15% of folks are actually billing right now for what they're doing, as well as access time, and the worry about patient availability when schools and work open up again. The good news, however, was that most programs were able to sustain their mental health funding and services unchanged during COVID. And those 12% that were reduced in funding, most were reduced by less than 50%. And 90% of folks felt that they were confident or extremely confident that their mental health services, including all their screenings and treatment, will continue in the same manner it did before the crisis after the pandemic resolves. As a result of all of this data, the Mental Health Advisory Committee had some wellness sessions for the community, including wellness using the Face COVID framework and what's in your control, and how to navigate uncertainty. We also want to be mindful that healthcare workers are at increased risk, and that our CF providers, you know, many of our pulmonologists and intensivists were pulled to the first line. And we've learned from studies that have come out of other countries that our healthcare providers are also at increased risk for anxiety and depression, with 13% of individuals screened with moderate to severe symptoms of anxiety and depression, and many suffering from insomnia. There was also a study that came out of Italy using our same screening tools, the PHQ-9 and GAD-7, finding that 20% of healthcare workers had moderate to severe anxiety and 25% depression. There was also high rates of trauma symptoms, and many folks, again, were experiencing insomnia. So our mental health committee has resources, wellness resources for healthcare providers that are still available online, from sessions on community and hope. So in conclusion, pandemics are associated with elevated mental health risk. The general population is highly or seriously distressed in about 30% of the cases. And similarly, 30% of our persons with CF have experienced a major impact on their mental health. In individuals with CF, 12 to 13% are experiencing moderate to severe symptoms of anxiety and depression, and 3% are endorsing suicidal ideation. So this is really a call to begin screening again for those centers that have stopped and to continue to provide your services within the clinic. Here are some additional references and resources, including Psych Hub, which has compiled resources from many of our country's best resources on mental health during COVID. So a big thank you to the Mental Health Advisory Committee, Janice Abbott and Alexander Quittner, for helping with the survey, the analytics, the statistical work, and the rest of this wonderful committee. And I want to conclude with saying there is no health without mental health. Thank you all.
I want to thank the organizers for inviting me today to talk about re-entry considerations and challenges in the COVID-19 world that we all find ourselves in. Today, I'm going to be talking about reopening CF clinics and providing safe care, going back to school or returning to the workplace, some testing considerations, and then with a brief discussion of vaccinations. And I'm going to try to do this through the lenses of our public health response, growing knowledge, and lessons learned. I experienced many challenges in preparing this talk. Regional differences exist for COVID-19 case rates, local resources, and regulatory requirements. This is a map of the United States showing the cases reported to the CDC over the 7 days previously, and you'll note the different colors with the darkest orange representing the largest number of cases. So what do we know thus far about CF and COVID-19? Thus far, data suggests that people with CF have similar disease manifestations and severity when compared to the general population. There's also been a suggestion of potentially a lower incidence in CF than the general population, which may be confounded by the generally younger age of people with CF, meaning that they were less likely to manifest symptoms. But there may be some biologic and behavioral protective mechanisms that have been speculated, which could include the infection prevention and control practices that people with CF have been engaged in for quite a while, which may have protected them from COVID. But the long-term effects on health and well-being are unknown. I want to give you a glimpse of the impact of COVID-19 pandemic on CF care thus far. I am involved in a study with Marion Molbeck and John LaPuma, and we surveyed 20 CF care centers in the United States to assess the impact of COVID-19. These are centers participating in an infection prevention and control study that we're doing. The centers closed their routine in-person care between March 16th and the 31st. But after that, they expanded their options for telehealth, for respiratory cultures, which mostly consisted of self-collection from sputum producers, although 2 of the sites created instructions for collecting throat swabs from children. They also expanded options for pulmonary function tests in clinic, offsite, and home. In the survey conducted at the end of June, only 50% of the sites had PFTs available. In the survey conducted at the end of August, that had increased so that 75% of the sites had PFTs available. So let me share with you the data that we got from the pediatric centers. So these were estimates that our sites gave us of their patients who had not completed these activities since clinic closure. So we're going to focus on being seen in person, having had a respiratory culture, or having performed spirometry. And the different colors of the histogram reflect the proportion of patients who had not yet completed activities. So if we focus on in-person visits, half of the sites reported that between 41 and 60% of their patients had not yet had an in-person visit. One of the sites estimated that this was actually 61 to 80%, and one of the sites said 81 to 100%. In terms of completing a respiratory culture, 4 sites reported that 41 to 60% of their patients had not had a respiratory culture, and 2 of the sites reported that 61 to 80% of their patients had not. And in terms of performing spirometry, despite trying to expand resources, 6 of the sites reported that 41 to 60% of their patients had not had spirometry. So clearly the long-term impacts of these clinic closures could have adverse effects on our patients because they weren't being able to be cared for in the routine ways that we usually care for people. So what are some of the strategies to allow opening of CF clinics safely? Education and frequent written communication between CF care teams, local infection prevention and control teams, the administration, and patients and families is clearly crucial. And I would argue that you can't communicate enough. This is a time when people need a lot of communication, clearly. Signage, we found in our site that clear signage is very, very comforting to patients. And in addition, social distancing cues, such as decals on the floor that tell people where to stand to avoid being too close to others. Universal PPE, which I'll talk a little bit more about in a moment, an emphasis on hand hygiene, cleaning and disinfection of the environment, telehealth, and feedback from stakeholders. And I've given asterisks to the practices that the CF community has been engaged with for years. Also, we have to have a consistent emphasis on consistent COVID-safe practice. I think that a lot of us have experienced COVID fatigue, which is completely understandable, but we need to continue to emphasize the practices that we know are evidence-based and worked. And I'll just pause for a moment on proper masking. I think we've all observed that we see people that aren't necessarily wearing their masks, covering their noses, covering their mouths, and tucked securely under their chin. But this is really worth watching and really worth emphasizing for our staff as well as our patients and visitors. But there are some challenges to this concept of universal PPE and social distancing. So we're asking our patients and our visitors to wear either surgical face masks or cloth face coverings, but we'll remind ourselves that these face coverings are source control. They aren't really PPE, but they do definitively reduce COVID-19 cases. In contrast, we ask our healthcare workers only to wear surgical face masks. This is both source control as well as protecting themselves from getting infected. Now we're asking that N95s be worn for all aerosol generating procedures in case a patient is asymptomatic or pre-symptomatic and we don't know that they are infected with SARS-CoV-2. We're also asking everyone to wear eye protection when caring for all patients. But we and others are experiencing challenges of adherence to these requirements. And I will emphasize that healthcare workers really need to understand the why universal eye protection is recommended. It's known that respiratory viruses, including influenza, can infect people via mucous membranes of the mouth, the eyes, and the nose. And regular glasses are not considered protective. So we continually have to reinforce this message with our healthcare providers. We now know that PPE prevents COVID-19 among healthcare workers. A study in Paris found that universal masking, whenever healthcare workers were around anyone, including one another or patients, N95s for aerosol generating procedures, reinforcing hand hygiene, and social distancing reduced healthcare worker illness despite a time when the wave of COVID-19 cases were increasing and people were having increasing exposures. Healthcare worker illness declined. In Padua, Italy, the use of FFP respirators, which is similar to our N95s, face shields, gloves, gowns, and monitoring healthcare workers by SARS-CoV-2 testing every 7 to 10 days, all of the healthcare workers tested negative. There's also been a systematic review showing that masks are protective, as well as a meta-analysis showing that both masks and eye protection are protective. So PPE does work. I'll now turn to the challenges of opening PFT labs. In a statement from ATS, there is concern that PFTs are avenues for COVID transmission, congregation of patients with lung disease, coughing, and droplet formation. It's crucial to implement strategies to reduce the risk of transmission, screening patients for symptoms, which clearly are likely to be present in individuals with lung disease, screening for travel, and I'm adding COVID-19 exposures, and limiting testing to essential tests needed for immediate decisions. But this paradigm is actually different than the way that we use pulmonary function tests in CF to monitor lung health. So I'll pause on the concept of aerosol generating procedures for a moment. Unfortunately, there's no definitive list of what constitutes an aerosol generating procedure. This is based on observational studies of transmission, experimental models, and the plausibility. It's also challenged because we know that there are multiple routes of SARS-CoV-2 transmission. There's close-range aerosol transmission by droplets and inhalation of droplet nuclei, contact from self-inoculation of SARS-CoV-2 into our eyes, nose, or mouth, but it doesn't appear that long-range aerosol transmission, such as occurs with measles, is an important route of transmission for SARS-CoV-2. This is based on observations of the R0, which is the number of patients that are infected should no protective mechanisms be in place. It's estimated that for SARS-CoV-2, it's about 2 to 3 individuals, more consistent with droplet transmission, in contrast to measles, which is truly long-range aerosol transmission, which has an R0 of 18. So how can we perform PFTs safely in clinic? First, emphasizing consistent use of COVID-safe practices in the community so that our patients can avoid infections. Screening patients and any accompanying family members for symptoms, fever, exposure to newly diagnosed persons with COVID-19 and travel, and again, universal PPE and consistent use of universal PPE in clinic. And then 4 potential strategies, and I'm going to emphasize one size cannot fit all because we have variable architecture and resources, HEPA filters, negative pressure, PFTs performed in an exam room, and waiting 30 minutes between patients. Staff PPE, hand hygiene, and N95, eye protection, gowns and gloves, and I'll emphasize booster education and observations for PPE donning and doffing, and then cleaning and disinfecting the lab or the equipment using a checklist and adhering to that checklist. And institutions may choose to perform SARS-CoV-2 PCR testing prior to pulmonary function tests if feasible and available. Reopening K-12 schools safely represents unprecedented challenges for education. State and local jurisdictions are working to implement proven mitigation strategies that they're adjusting to the needs and circumstances of local communities. And I'm purposely putting proven in quotes because honestly, we don't yet know about these mitigation strategies really clearly in schools. And I'm confident that these strategies will need revision and have to be adapted if our COVID-19 case rates change, and particularly within schools. So what are the considerations for reopening schools? We need to ensure that families understand the risks and the benefits of in-person learning. And there's a really nice CDC interactive tool that I urge you to look at, and it sort of maps out what people should be thinking about with regard to returning to school. We now know that COVID-19 poses less risk to children, but infections still do occur and can pose a risk to the adults. Social, emotional, behavioral, and mental health benefits of in-person learning are clearly important and well spelled out in an American Academy of Pediatrics document. Also, schools maintain critical services to help mitigate health disparities that have become all too vivid during the COVID-19 pandemic, such as breakfast and lunch programs, after-school programs, and mental health services. Schools need to provide consistent behaviors and model consistent behaviors to reduce spread. And we've talked about these already, but I'll mention how to monitor children for signs and symptoms and having policies for students and teachers and staff for staying home and returning to school. And also having emergency operation plans for how to manage children's teachers and staff who have COVID-like illness, testing strategies, or people that actually have confirmed COVID-19, as well as having transparent criteria for suspending and resuming in-person learning. I just want to briefly go over this concept of continuum of risk. And there are low, medium, and high risk scenarios. So I'm just going to focus on the medium risk, but you can read more about it on the AAP document that I mentioned before. In the hybrid learning model, most students experience in-person learning and some virtual learning. There's cohorting and alternating schedules and staggered schedules, but some mixing of groups of students and teachers throughout and across school days does occur. Students and teachers minimally share objects. Students, teachers, and staff follow all recommendations, such as face masking, social distancing, hand hygiene, again, the list we've been discussing. And there's regularly scheduled cleaning and disinfection of frequently touched areas that are implemented with fidelity. Again, this consistent approach. And again, you can read more about these continuums of risk to help families interpret what their schools are doing to understand the potential risks that their strategies are posing. There are, however, unique considerations for the student with CF. First, and probably foremost, confidence in local implementation of the mitigation strategies. Again, the continuum of risk. The ability of a child to reliably wear a mask. Potential hearing disabilities, from, for example, tobramycin. A child will have difficulty understanding a teacher wearing a mask. If a child has the need for routine visits to the school nurse, that could pose a larger risk because they might be coming into contact with ill students at the school nurse. CF respiratory symptoms may mimic those of COVID-19, so the schools are going to have to be very sensitive to that if symptom screening occurs. Baseline lung function may affect decision-making, transportation methods for getting to schools, and even the composition of the student's household, if there are other high-risk individuals in the household. There are numerous challenges for returning to work, and so I chose to express this as questions that I would pose to an adult returning to work to think about. Is working remotely feasible and productive? How will they travel to work? Do they have to share an office? Because that would make social distancing very challenging. Is social distancing endorsed and consistently implemented in their workplace? Is mask use non-negotiable in the workplace? What about bathrooms? Where will breaks and lunch occur? Are there any shared object or surfaces in the workplace? How are these cleaned and disinfected? Can the individual maintain their CF care regimen within the altered workplace? Is there good access to testing if needed? Is there transparency disclosing the presence of a confirmed COVID-19 case within the workplace? And are there transparent plans for closing and resuming in-person work? And again, I refer you to the CDC website, where there's a very nice document outlining many of these considerations in more detail. Briefly, I want to discuss testing options for SARS-CoV-2. I think we're in a very, very complex landscape. So we'll briefly talk about PCR testing, antibody testing, and antigen testing. The source of PCR remains nasopharyngeal as the gold standard, but you could understand that there's increasing interest in utilizing other sites such as nasal swabs and saliva because of the ease of obtaining. The PCR assays detect envelope, spike, and nucleocapsid viral RNA. They do not react with other coronaviruses. The very exciting news about collecting saliva came out of a recent study from Yale. And the benefits of collecting saliva are that they avoid healthcare worker exposure, they reduce the use of these precious test kits and personal protective equipment, And now in this Yale study I talk about and cite below, there may be a higher viral load in saliva. PCR assays are most sensitive during acute infection, but we've all experienced the complication of prolonged shedding, meaning detection of viral RNA for weeks and even months after acute infection. But we're learning progressively that this does not represent viable and transmissible virus. And finally, I'll mention that MP swabs in particular may have false negatives if appropriate sampling does not occur. Antibodies are done on blood, and the antibody tests that are available through FDA emergency use authorization at this time detect IgM, IgA, and/or IgA against the viral proteins, generally S and N. They can measure past infection, vaccine response, and hopefully protection. But measurement of antibody does not imply always neutralizing or protective antibody. And the duration of detection and protection remains unknown. And in milder disease, people actually make less or even undetectable antibody. We're all hoping for an amnestic response, whereby the T cell response and the B cell response to produce antibody gets basically turned on with repeat exposure if there is a repeat infection or following vaccination. But again, this remains to be seen. And I'll end with antigens, which generally now are done with a nasal swab. They detect SARS-CoV-2 antigens or proteins, and they have very rapid turnaround time, and they can actually have point-of-care testing. So there could be a benefit and there could be a use for this, but they're in less utilization currently. There's also a very nice document on the CDC website describing the different types of tests and where they're best utilized. Antigen testing is best used early in infection when the viral load is highest. Maintaining suppression for SARS-CoV-2 is really our biggest challenge, and that's going to have to be a vaccine. We're going to have to demonstrate efficacy, rapid approval with adequate and equitable distribution, and acceptability to a population where there is a fair amount of vaccine hesitancy. I think that will be magnified with a new vaccine, despite the very big fears about SARS-CoV-2. And I want to just say that even should there be a vaccine, I'll refer you to this editorial, that we should stop expecting life to go back to normal next year. It may take longer. I'll take a moment here to just emphasize how crucially important influenza vaccination is. Tremendous amounts of concern about the impact of seasonal influenza and COVID-19 pandemic at the same time. Co-infection can occur and could be clinically severe. People at high risk for severe flu are also at high risk for severe COVID-19. And the symptoms of influenza mimic those of COVID-19. So what does that mean for us as healthcare workers? We may have to be furloughed if we become ill until influenza is confirmed and COVID-19 is ruled out. We certainly know that influenza vaccine reduces the risk of illness, hospitalization, and death, and preventing influenza will help us to conserve precious healthcare resources. And I truly hope that thanks to all the things we're doing to prevent COVID-19, that we'll have a more mild flu season. But obviously, we have to wait and see if that's true. There's a tremendous psychological impact of crises on communication. People experience denial, fear, anxiety, confusion, dread, hopelessness or helplessness. And all of this really impacts the way that they hear messaging. So people tend to simplify messages, they hold on to their current beliefs, they look for additional information and opinions that shore up these beliefs, and oftentimes they believe they're the first messages that they hear. And we certainly know that during the COVID-19 pandemic, some of those early messages actually proved to be incorrect. So I want to leave you with that in this time of re-entry challenges, stress, and uncertainty, the CF care teams are a trusted source of information, and you continue to provide that to your patients and your families. So thank you so much for this opportunity today. Stay safe and healthy, and don't forget to take care of yourselves.
Hi everyone, my name is Laura Beth Rubsich and I'm a physician assistant at the UNC Adult CF Center in Chapel Hill, North Carolina. I'm going to talk to you today about home spirometry strategies for implementation. Please feel free to submit a question for the Q&A live session, interact in the chat box, or connect with me on the networking platform. There are no relationships to disclose related to this presentation. Our objectives today will be to recognize the importance of spirometry in CF, discuss the increased need for and benefits of home spirometry, review how to implement a home spirometry program, summarize the challenges of home spirometry, and consider next steps for the future. Spirometry is important in CF. That's really why we're talking about home spirometry today. Once the patient is old enough, spirometry is performed at regular intervals, usually every 3 months. It's part of our CF Foundation guidelines and checklists. Also, it's a reliable indicator of acute changes in lung function, and it helps us detect exacerbations and monitors response to therapy. Despite aggressive therapy, lung function declines as patients get older. And based on our own experience, we know this pattern can vary. It can happen in a linear fashion, as a sudden drop, or as a stepwise decline. Overall, FEV1 is correlated with survival in CF. Due to COVID-19, our clinics transitioned to remote care earlier this year. Although remote care has its benefits, it's made it challenging and almost impossible to monitor lung function at home. Symptoms don't always correlate with lung function, and patients sometimes underreport their symptoms. Home spirometry provides the objective data we need. So how does home spirometry fit in, and has this been looked at in the past? The EICE trial was a multi-center randomized controlled trial from 2011 to 2015. They enrolled 267 patients and compared 2 patient groups, one with home spirometers and one with usual care. In the first group, they checked their home spirometry and their symptoms twice a week. In the usual care group, they followed up every 3 months and contacted their care team for any concerning symptoms. Over a 52-week period, the results showed that with home spirometry, more exacerbations were detected than usual care, but it did not result in a slower decline in lung function. Although an impact on lung function wasn't seen, I believe this study still really applies to what we're dealing with at this moment. In this age of virtual care and COVID-19, we need increased access to care and data at home. In addition, it's more important than ever to detect exacerbations and infections early. In 2010, we did a QI project at our adult center at Chapel Hill. We distributed home spirometers to 90 patients with logbooks to monitor their symptoms. We found a home spirometry program to be feasible, as evidenced by a high usage rate among patients returning to clinic. We surveyed participants, and among the patients that used their home spirometers, they found it helpful in detecting exacerbations early and maintaining their lung function. We also surveyed non-users and found that they had an aversion to seeing their FEV1 values. We know that this is a psychological barrier that many of our patients are dealing with, and this is definitely a topic that we should explore further. Lastly, home spirometry has become the standard of care in some lung transplant centers. It is utilized to detect rejection and infection earlier. And since home spirometry is more established in this patient population, we should consider collaborating with this group. So at this point, we've established that home spirometers can help us overcome the challenge of remote care in CF. But like everything in healthcare, there are always barriers. We've tried to get our patients home spirometers in the past, but they're expensive and most insurance companies don't pay for them. Almost as soon as the COVID-19 pandemic hit, the CF Foundation rose to the occasion and pledged to fund home spirometers for our patients. Initially, this was 10% of each center's patient population, and now it's up to 50% and possibly more. We thank the CF Foundation for providing this amazing resource. The CF Foundation has partnered with a company named ZephyrX, who is distributing the home spirometers and providing their online provider dashboard for remote monitoring. The device is called the Mir SpiroBank Smart Spirometer. It's Bluetooth enabled and pairs with a smartphone or tablet. If the patient chooses to share their data, their reports will be uploaded to the provider dashboard. On this resource, members of the team will be able to view the patient's spirometry trends and reports. The dashboard does have a fee per patient per month that is charged to the individual CF center. The fee is only charged if the spirometer is actually used in that month. As you can see here, the cost decreases depending on the number of patients enrolled. This resource has been free up until now and until the end of September. So now I'd like to move on to the most important part of my talk, which is about how to implement a home spirometry program. Over the past couple of months, I've been organizing a home spirometry program for our adult center, along with several other team members. The first component is to determine who's going to be involved. For our own clinic, the nurse coordinators have been the point of contact for ZephyrX. They've been keeping track of which patients have been selected for each wave of spirometers, and they alert the patients when the spirometer is going to ship out. For myself, as the APP, I've been involved in developing the program, especially in terms of patient education, overseeing the dashboard, and interpreting the spirometry reports that come in. This project could be led by a nurse coordinator, a respiratory therapist, an MD, or it could be a combined effort. Next, you should educate yourself. As a team, we scheduled a virtual meeting with ZephyrX and went over their tutorial on how to use the spirometer, the app, and the dashboard. On top of that, we have our own home spirometer, and I've been able to practice on it myself so that I understand the steps for the patient. And lastly, I've shadowed our PFT techs in clinic on several occasions, and they have been able to give me a ton of useful tips to share with the patients. After that, you'll need to consider the financial aspect of the program. Where will the funds for the dashboard come from? Will they come from the clinic, through the hospital, from CF center funds, or elsewhere? The financial aspect of the program will be individual for each CF center, and you must communicate with your own billing department to understand the flow of funds. Then you'll need to determine the CPT codes you're going to use. After researching a lot on my own and discussing with others, including ZephyrX, other CF centers, and our own billing department, we decided on the following codes. 99453, which is for the initial setup and patient education on use of remote monitoring equipment, and 94014, which is for patient-initiated spirometry and can be billed every 30 days. It includes reinforced education, analysis of data, and interpretation by a physician or other qualified healthcare professional. We felt that these codes best fit what our goals were for the program. we ruled out some of these other codes for a variety of reasons. And lastly, you'll need to understand what the reimbursement is going to look like for the codes you've chosen. I have spent a lot of time communicating with our coders for the clinic and understanding a lot of the billing nuances. For example, when these codes are billed by an APP, similar to other services, the reimbursement is 85% of what a physician would be reimbursed. Here is a table showing the reimbursement for the codes that we have chosen based on whether the insurance is Medicare versus commercial insurance. Of note, there is no copay for Medicaid patients. For 99453, you can see here that Medicare allows a reimbursement of about $17. The patient cost share would end up being about $3 to $4, depending on whether it's billed by a physician or an APP. For this code, commercial insurance allows a reimbursement of about $43, and the patient cost share would range from about $11 to $13. For 94014, which is for our monthly monitoring, Medicare allows a reimbursement of about $54. The patient cost share would range from about $9 to $11. And finally, commercial insurance would allow a reimbursement of about $62 for this code, and the patient cost share would range from about $16 to $19. So now I'd like to move on to the home spirometry program itself and the components of it. Here is an example of our welcome letter. After the spirometer is shipped out to the patient, our nurse coordinators are sending them this letter through their patient portal. The letter template was created by ZephyrX, and we added our own recommendations. For example, we're recommending that the patient uses their home spirometer 3 times in the first week, followed by a test every 1 to 2 weeks. Also, we're letting the patient know that we will be contacting them for further education. The next component of the home spirometry program is the education visit. What I'm finding is that some of the patients have set up the home spirometer on their own without any difficulty, but there's a good amount of patients that are having difficulty or who haven't even taken it out of the box. For the latter group, they need an education visit. I'm doing these virtually or in person. I've created a note template in Epic, and in that note, I am documenting their consent to enroll in the program and possibly have a small copayment. During our visit, we review their baseline FEV1 and how to handle any changes that they may encounter. For example, if their FEV1 is down from baseline, they're advised to repeat the test daily for 3 days. If they see a 10% drop in their FEV1 that does not reverse itself on retesting, or that is accompanied by symptoms, they're advised to contact us. For the education visits, I'm billing for the code 99453. Now for the patients that already have a hang on it, I'm reaching out to them and briefly reviewing the important points and consenting them to participate in the program. I'm documenting this, but I'm not billing for it unless it becomes a more prolonged visit. Here's an example of my education visit note template in Epic. And it includes all of the points that I just reviewed. The final part of the home spirometry program is the monthly monitoring. Here is an example of the note template that I'm putting in Epic for this portion. And what's happening is at the end of each month, I'm reviewing all of the reports that come in through the dashboard. I documented in a note the following: how many tests were performed in the last month, the interpretation of their most recent test, their best FEV1 in the last year, and the quality of their test. I'm snipping in an image of their spirometry report and their flow volume loop, and then I'm including any recommendations. This could include continued routine monitoring, repeat home testing, a phone call from the nurse, or the need for a scheduled visit. I'm sending these recommendations to the patient through their patient portal, and I'm only including their primary pulmonologist on the note if the patient is not at their baseline. I'm documenting all of this in a patient outreach encounter, and I'm billing for the code 94014. In our short time of using these home spirometers, we've already found it extremely helpful. For example, we had a patient that developed increased respiratory symptoms. They used their home spirometer and their FEV was stable. We felt their symptoms were related to asthma and allergies, and they were treated with a prednisone taper alone instead of antibiotics. The patient clinically improved. In another example, a patient developed increased respiratory symptoms again. However, their FEV1 was significantly decreased on their home spirometer. They were ruled out for COVID-19 and treated with oral antibiotics. They repeated their home spirometer every few days, showing a gradual improvement back to baseline. In both of these cases, the home spirometer was a vital tool in guiding our treatment plan. Coming towards the end of my talk, I'd like to touch on the challenges of home spirometry. Home spirometry, and really all spirometry, is technique driven. There are a lot of patients who really depend on the coaching they receive in the PFT lab, and they're going to have more difficulty getting used to it at home. Fortunately, ZephyrX is planning on a software update coming soon that includes live coaching through the app. Also, using a home spirometer is more difficult for patients who are not technologically savvy. Some patients have a very easy time setting up a device, and other patients definitely do not. As mentioned before, some patients have significant anxiety seeing their PFT numbers, and they'll decline to receive a home spirometer or use one. And last but not least, it's unclear whether the insurance companies will reimburse for a home spirometry program. In conclusion, as we've discussed in this talk, home spirometry is increasing in need for the CF patient population and is definitely beneficial. As far as our next steps, we need to determine whether the charges are being reimbursed. And if not, how do we approach that as a clinic and as a CF community? Also, I believe it's important to gather feedback from our CF team members and patients through surveys. And lastly, I know that a lot of other clinics are developing their own home spirometry programs, and this conference is a great opportunity for us to learn from each other. Thank you so much for listening today, and I look forward to connecting with many of you later on.